Hello everyone, welcome back to my channel Medical Approach. This is Shubham and today we are going to discuss about the peptic ulcer disease. So let's talk about this. So if we talk about the peptic ulcer disease, let's see first of all, let's understand it. What is the meaning of it? We know that peptic ulcer disease means we are going to talk about the ulcers, and first impression is like these ulcers are going to be in the stomach. Okay, yeah, that's true, but I would say that that is the partial true statement because duodenal ulcers are more common as compared to the gastric ulcers, so which means that ulcers might be present in the stomach as well as in the duodenum. Okay, so let's talk about this further, what I'm trying to depict right now. Okay, so basically ulcers means that they are, so what are the ulcers? Okay, they are basically the erosions. Okay, I would say they are basically the erosions or some kind of defects in the epithelial lining. Okay, in the epithelial lining of either stomach. Okay, epithelial lining of either stomach or duodenum, because as I said that it might happen, these ulcers might develop in the stomach or they might develop in the duodenum as well. Okay, so both are important for us to remember. Okay, now next thing is as I said, the two types of the ulcers over here. Okay, so I talked about the types over here itself, so let's see what I'm discussing about. So I said that there are two types, so there can be the gastric ulcers, right? If there is the any kind of erosion or defect in the epithelial lining of the stomach, then I would say that they can be gastric ulcers. On the other side, if that defect is happening in the duodenal lining, then it can be the duodenal ulcers as well. Okay, duodenal ulcers. Fine, so there are two kinds of ulcers we have just read. There are the gastric ulcers or duodenal ulcers. Okay, now guys, what happened is whenever you are eating the food, if let's say if some person is having the gastric ulcers, so these persons actually usually they actually avoid to eat the food. Why is it so? So what I said is that these kind of people, they will be avoiding the food. Okay, and these kind of people they will be snacking. Snacking means they will be eating anything every 2 to 3 hours, and due to this, these gastric ulcer patient, they will be weight loss. Okay, not every patient, but most of it most of the patient who are having the gastric ulcers, they will be having weight loss because they don't want to eat anything, because of because as they will eat, they know that the pain will be starting right in the stomach. And duodenal ulcers, they will be snacking every 2 to 3 hours because these are the hunger pains. Means we are calling them as hunger pains because if they will not eat, then pain actually starts at that time. We will be discussing about that, how is it happening. So duodenal ulcers patient, there will be the weight gain. Okay, in most of them who are having the duodenal ulcers, they will be having the weight gain property because of snacking every 2 to 3 hours or eating every 2 to 3 hours. Okay, so that's the case. Now let's understand what I am talking about. So let's say a very simple diagram I will draw in front of you. So here is the esophagus, and here I have tried to draw the stomach, and then it is continuing like this as a duodenum. Okay, now let's say here is the ulcer. So there is a ulcer over here. Let's say it is present in the stomach wall. Okay, it is present in the stomach wall. Now what will be happening? As this person will be eating the food, this person will be eating anything. Okay, as this person will be eating the food, this food bolus will be coming over here, right? And then it will be coming over here. And as we are eating food in the stomach, we know that acid secretion will start up. Due to the secretion of acid, okay, they will be invading the, so what I'm saying, they will be invading this ulcer also, and that's how the pain starts. So whenever they are eating the food, the pain will be aggravating in these patients. On the other hand, if I will talk about the patient who are having the duodenal ulcer, so let's say what is happening in them. So again guys, this is the esophagus, then stomach, and then duodenum, a very simple diagram, right? And now let's say this patient is having the ulcer over here. Okay, usually they are having the ulcer in the initial or proximal part of the duodenum. So let's say there is a ulcer. Okay, so here I have depicted the ulcer. I have tried to depict the ulcer over here. Now what will be happening as these patients will be eating anything? Okay, now these patients, same thing, as they will be eating anything, this food bolus now will be, okay, passing through the stomach, and then it will be finally going to the duodenum, isn't it? Now what will be happening? We know that in the intestine, in the small intestine mainly, and duodenum is the initial part of the small intestine, isn't it? In the intestine, to digest the food, in order to digest the food, we need the alkaline environment. So that's why, due to the alkaline environment in the intestine, what will be happening as the person will be eating the food, and there will be the alkaline environment in the small intestine due to the secretions which are coming from the pancreatic duct, isn't it? You know about that hepatobiliary physiology, that how when you are eating the food, then cholecystokinin and secretin will be releasing, and from the pancreas there will be the secretions which are actually the mucus and bicarbonate products will be coming in the duodenum region, and they will be helping us to digest our food. Now what will be happening as the person will be eating the food? So there will be the alkaline environment, and then due to the alkaline environment, this person will be relieving the pain. Okay, this person, the pain of this person will be relieving by eating the food due to the alkaline environment, and that's why this person likes to eat food every 2 to 3 hours. Generally we are eating the food every 5 to 6 hours, but these persons they will be eating, they actually prefer to eat every 2 to 3 hours, and that's why the weight gain component comes over here. So I hope you understood about this, that how the gastric ulcers and duodenal ulcers differ from each other, and I have tried to depict them with the help of a diagram as well. Okay, now I'm moving on and now we'll be talking about some causes. So if I will talk about the gastric ulcer, the first major cause over here. So now I'm going to talk about the causes. So what will be the causes over here, and what will be the causes over here? Okay, just remember that on the left side I'm going to write for the gastric ulcers, and on the right side I'm going to write for the duodenal ulcers. So let's talk about the gastric ulcer causes. So here the first one is which you need to remember over here, that is the Helicobacter pylori, and I'm writing over here H. pylori. Okay, so Helicobacter pylori is the major cause for causing the gastric ulcers. Okay, and second one, as we know that painkillers, which comes under the category of non-steroidal anti-inflammatory drugs, which are NSAIDs, they actually become the fashion nowadays, because most of the people are taking the NSAIDs, preferring the NSAIDs for their as a painkiller. Okay, and due to that we know very well that, for an example, here I would like to write the example as well, and I'm talking about the aspirin, which is the most common drug which we are using nowadays to avoid the pain, right, for the painkiller purpose. Now what will be happening, guys? As this person is taking the painkiller for a longer period of time, and let's say this person was taking aspirin for 6 months or a year, and during that much long period, if these persons are taking NSAID, then what may happen, because we know what is the mechanism of action, it will be inhibiting what? It will be inhibiting the COX-1. Okay, very right, cyclooxygenase enzyme 1. So what the COX-1 is doing? COX-1 is very important for the prostaglandins, isn't it? Now if the aspirin will be inhibiting the prostaglandins, then what will happen? Indirectly aspirin is inhibiting the prostaglandin. Okay, indirectly aspirin is inhibiting the prostaglandins, right? And that's why, and prostaglandins is what? Prostaglandins are the protective factor. Prostaglandins are what? Prostaglandins are the protective factor for GI lining. okay, protective for GI lining. So this protection will be compromised. This protection will be compromised now, and that's how the gastric ulcer component may come in the patient. Okay, so that's how the gastric ulcers component may come in the patient. Okay. On the other hand, if I talk about the duodenal ulcers, the same cause I would write over here as well, that H. pylori is the main ghost over here, which is causing the development of duodenal ulcers. Okay, but the NSAIDS component, they are mainly causing the gastric ulcers as compared to the duodenal ulcers incidence. Okay, now some common causes over here, and I would say that they can be considered under the risk factors. So what are the risk factors for development of ulcers? And I am generally using the term as peptic ulcer. Peptic ulcer, I will be using this term as general for gastric as well as duodenal ulcers. So let's talk about the risk factors. What can be the risk factors? So two risk factors I've already talked about, and these are very clear in our mind, that H. pylori, definitely this is the risk factor if some person is having this bacteria in the GIT, and so this person might be having this. And second one, we talked about the NSAIDs as well. So H. pylori, okay, Helicobacter pylori, and then we have talked about the NSAIDs as well, non-steroidal anti-inflammatory drugs, right? Then what is the thing? Progression of the age. As the age progresses, we know that many kind of things, many kind of diseases are actually ready to attack our body, and progression of age can also be the risk factor. Then smoking, definitely smoking is also a very common risk factor for many diseases. And then as the lifestyle, everybody knows about the stress, so that will also cause a problem, right? So these are some of the risk factors which can be considered as a common risk factor for causing the peptic ulcer disease, which means either gastric or either duodenal ulcers might develop over here. Okay, now I will be going to the pathogenesis part, that how the things will be causing, these things might cause the development of the peptic ulcer disease. So if you talk about the pathogenesis part over here, then I would say that there are two factors actually. Okay, what are these two factors? Look, one is the protective factor and one is the damaging factor, which is causing the damage to the GI. Okay, so one is the protecting factor and one is the damaging factor. Okay, now if I will be talking about the H. pylori component, okay, so if I will be talking about H. pylori, we will be talking about one by one. So if I will talk about H. pylori, how it is causing the development of peptic ulcer. Okay, so it is having a special property to secrete an enzyme. Okay, it is having the special property to secrete an enzyme, and the name of this enzyme is urease. Okay, what is the name of the enzyme? The name of the enzyme is urease. Now what this urease will be doing, this will be creating an alkaline environment. It will be creating an alkaline environment for itself. Okay, now how will it cause the problem? The problem is whenever it will be creating an alkaline environment, this will help this bacteria to survive. Okay, so this increases the chances of survival of this bacteria. Okay, that is the main thing, and that's how they can survive for a longer period of time in the GI. Okay, so that is the first thing. So that's how the H. pylori is working. Okay, one more thing, on the other side, what may happen? On the other side, what may happen is that, you know, our inflammatory cytokines, means various kind of I would say biologically active substances, what they can do, they can inhibit. So I am writing just cytokines. Okay, cytokines. Now what they can do, cytokines, they can inhibit parietal cell acid secretion. Okay, what they can inhibit? They can inhibit parietal cell, and if they will be inhibiting parietal cell, then acid secretion will be inhibited as well. So acid secretion will also be compromised over here. As the acid secretion will be compromising, then there are the chances of development of what? Gastric ulcers, isn't it? Now, because look, if there will be much more acid, then ulcer will not be able to develop over there. if there will be less acid, then there are more chances of development of the ulcer over there. Okay, and because we know that in the stomach there is a plenty amount of acid present over there. Okay, if we talk about the pH also, we are having 3 to 4 pH range, that much acidic our stomach is. But still, if there is the inhibition of the parietal cells who are responsible for secreting the acid over there, if due to some reason, due to the release of some special kind of cytokines, inflammatory cytokines, what they can do, they can actually cause the inhibition of the parietal cell, and due to that acid secretion will be inhibiting, and due to that there might be the development of gastric ulcer. There might be the development of gastric ulcer. Okay, so these are two hypotheses for the development of the ulcers over there. Okay, now how the NSAID, so that was about the H pylori component. Okay, which H pylori can do in our body. Now second component over here I would like to add. So this was the first one, and now the second component will be talking about that. So second component is due to NSAIDs, and now NSAIDs I told you already over there as well that what they will be doing. So once again I'm telling you that they will be inhibiting the COX-1, which is the cyclooxygenase enzyme, and if they will be inhibiting the COX-1, then what might happen? Yes, so there will be the inhibition of prostaglandins, isn't it? So there will be the inhibition of prostaglandins, and prostaglandins we need them for the secretion of mucus, and if the prostaglandins will be inhibiting, then mucus will also be inhibited. If the mucus will be inhibited, then obviously the protection system will also be inhibited. So protection of GI will also be inhibited, and that's how the ulcer might develop. Okay, right now I'm talking about the common peptic ulcer. I'm talking about, so either the gastric ulcers or either the duodenal ulcers might develop, but due to the NSAIDs, usually it has been seen that there is the development of gastric ulcers. Okay, now there are some other causes that I told you in the risk factors also, that there can be the stress, and there can be one more factor that there is the gastrinoma development might be there, so which is released by the JD syndrome, that is the Zollinger-Ellison syndrome. Okay, so Zollinger-Ellison syndrome is also one of the risk factor where it can secrete the gastrinoma. Everybody knows about that here we talk about the gastrinoma triangle, where the tumor is in the duodenum, or it can be in the pancreas, or then it can be in the stomach. But if the tumor is in the stomach also, it might cause hyper secretion, right? So it might cause the more and more acid secretion by stimulating the gastrin in the stomach. So tumor is in the duodenum, but it might cause more and more secretion of the acid in the stomach, and that can cause the development of ulcers too. Okay, so here it can stimulate the gastrin cells. Okay, so first of all there is a gastrinoma, and then it will be stimulating the gastrin to release more and more acid over there, and they might develop the ulcers then. Okay, so that is also one of the method. Fine, so we have talked about the several one over here. Now I will be talking about the presentation part, how this patient will be presenting to you. Okay, let's say the patient comes to you. So now we'll be talking about presentation part, how this patient will be presenting to you. Okay, so let's talk about that as well. So if you talk about the presentation, I'm talking about the just general symptoms, that how these patients will be coming up, and how this patient will be telling you that what kind of problems these patients are having. Okay, so first of all, very simple to understand that this patient will be having the abdominal pain. So no doubt about that this patient will be having abdominal pain, and most commonly it will be presenting, they will tell you that they are feeling the pain in the upper quadrant mainly. So they will be telling you that pain is mainly in the upper quadrant. Okay, upper quadrant mainly. Then there might be vomiting, mainly vomiting can be there for the patient who are having the gastric ulcers. Okay, patient who are having the gastric ulcers mainly. And why is it so? Because guys, I told you one diagram and with the help of diagram I will be telling you that what is happening. Because acid is present more proximally to the esophagus, then there can be what may happen, that there can be the reflux from here. The acid might might go into the esophagus, and then it might come out from the esophagus, and it may cause vomiting. Whereas sometimes may happen that these duodenal ulcers, okay, I'm talking about the duodenal ulcer now. In the duodenal ulcers, as they are more distally present to the esophagus, they might cause what? They might cause the flow in this direction, and due to that melena might happen. Okay, so very important that gastric ulcers might cause the vomiting, and duodenal ulcers might cause the melena. And what is the melena? Melena, they are the black tarry stools. Okay, you must have heard about them. So they are the black tarry stools because the blood will be presenting in the stools. Okay, so that's why. So we will be writing it over here as well in our discussion. So I told you that vomiting will be happening for the gastric ulcers, and melena component, which is the black tarry stools, so they will be present for the duodenal ulcers, okay, which we need to understand, and we talked about that as well. So they will be present for the duodenal ulcers. Okay, what else? I told you about the appetite also. So there will be poor appetite generally for the gastric ulcers patient mainly, isn't it? So I told you about that as well. And with that there can be other symptoms like belching or bloating, right? These kind of things the patient might tell you. Okay, now these are the symptoms which the patient will be telling you. Now upon physical exam, you will be doing the physical examination of the patient, and during the physical examination what can be the finding? Sometimes the finding can be much severe if the patient comes late, and one very drastic complication might happen in our patient. And what is that complication? I'm talking about the peritoneal signs might develop over there, and that may happen after perforation mainly. Unfortunately, God forbid, if the ulcer was present in the duodenum, let's say, or in the stomach as well, then what might happen? Then God save this patient, because if you know the anatomy, okay, I will go back to this diagram, and if the ulcer is present over here, then there is one artery which is present very closely to the stomach. Okay, and if the ulcer is present over there, that artery might bleed if it will perforate. So what I'm saying actually, I would repeat, if this ulcer over here, if it will perforate, then the adjacent structure to it will be damaged or will be actually getting the problem. So here the artery which I have showed over here, this is the left gastric artery. So this left gastric artery might bleed, isn't it? So this left gastric artery might bleed now, and due to that loss of blood might be happening, and then the person might go into the hypovolemic shock. Okay, hypovolemic shock. Or sometime what may happen, that the content of it, after the perforation, the content of it, they might go into the peritoneum, and they might cause peritonitis. So one chance is there that perforation can cause the problem in the left gastric artery, and then they might bleed, and then hypovolemic shock, and then finally the person may die also. So death may happen. So this is the one scenario which might happen. The other scenario which might happen is, I will depict it with the another color. So other scenario which might happen over here, that can be what? That can be peritonitis, because the fluid might leak into the peritoneum, and then from there it might cause what? Peritonitis. And that is also a very dangerous condition, and after peritonitis, if it will not be treated in time, then it might also cause the expiry of the patient, so death might happen there as well. Okay, so I told you two things which might happen over there, right? So that you need to understand that what can be the complication after the ulcer development also, okay, if the patient comes late to you. Okay, other than that, abdominal tenderness signs can be seen in the patient, that you know, sometimes the tenderness you might feel in the abdominal region. Okay, now I'm coming to the diagnostic part, that how you will be making up the diagnosis in our patient. Okay, so let's talk about the diagnosis part over here, that what are the criteria which we can use for making up the diagnosis over here. Okay, so first test, which is the best initial test over here, I would say, and here you can use the urease breath test. Okay, here we can use the urease breath test, and what will be happening, this is the, you know that nowadays there is a trend, or I would say the protocol of using the non-invasive test mainly, and this is the non-invasive test. Okay, that's why this is the initial test, I would say. So this is the best initial test for checking up. I'm not saying overall best, I'm just saying the best initial test, because it is non-invasive. So this is the urease breath test, which we can use for mainly diagnosing the H. pylori, because that is the major cause in 80% of the cases of the peptic ulcer disease. H. pylori is the culprit. Okay, H. pylori is the culprit, so that's why I said about that. Then second thing which comes into our mind, and that is the esophagogastroduodenoscopy. Means you will be checking the esophagus, you will be checking the stomach, you will be checking the duodenum, so everything you will be checking over here. Okay, so esophagogastroduodenoscopy. So one test was urease breath test, and another one is the esophagogastroduodenoscopy. Okay, here this is the gold standard. Now this is the gold standard test, but it is invasive, isn't it? So that's why I didn't wrote it on first preference. This is the second one. So whenever the patient comes to you first time, the urease breath test should be used, and then after that gold standard is the esophagogastroduodenoscopy, where we will be visualizing the esophagus part, where is the, because sometime near the lower esophageal sphincter ulcer might develop over there as well. Okay, but however that is rare, but it can be the probability. Okay, so esophagogastroduodenoscopy along with biopsy, I would say. Okay, so here I would like to add biopsy also, because if there is something abnormal you are seeing on your monitor with the help of esophagogastroduodenoscopy, okay, then you should take the biopsy from there to just check either it is benign ulcer or either is it malignant, because sometimes gastric ulcer might develop into malignancy. Duodenal ulcer are usually benign, but gastric ulcers might develop into malignancy as well. So you need to take the biopsy from there if something abnormal you are finding, and from that ulcer you will be taking the biopsy, you will be sending it to the histopath lab, and after that you will be deciding your treatment. Till then I will be talking about what drug has to be given to the patient, that is after the diagnosis part. So this is for the diagnostic part, that you are having the urease breath test, and you are having the esophagogastroduodenoscopy plus biopsy. Okay, one more test we are having right now, that is the CLO test. Okay, CLO test that is the Campylobacter jejuni like organism test. Okay, where we are having the slide kind of thing, where we'll be putting the tissue over there, and with the help of a reaction it will change the color. That is the CLO test. So that is also one of the tests which can be used as a diagnostic part of the peptic ulcer disease. Okay, now I'm coming to the last part over here, that is the treatment. So diagnosis has been made once, so now we should treat the patient. Now for the treatment part, what we will be doing, or the management, how the management is doing, because that is the most important thing which the patient is expecting from your side, isn't it? So here what we will be doing, so let's talk about that. So in the treatment part we'll be giving the drugs. So if it is H. pylori induced, I mean to say, if the H. pylori was causing the peptic ulcer disease, because I told you many causes, right? If the H. pylori is causing this, I'm saying H. pylori induced peptic ulcer disease, then what you need to do is you need to give the antibiotic, because H. pylori we know, Helicobacter pylori, this is the bacteria, right? And for treating the bacteria we need to give antibiotics. Now what antibiotic we will be giving over here? So a very famous therapy we are using, that is the cap therapy. Okay, so please remember like this, cap therapy, it will be easy for you. And what do I mean by that? For with the C, I am writing over here clarithromycin. You must have heard about this. Yes, clarithromycin. For A, I am writing the amoxicillin. Okay, amoxicillin. And with the P, any kind of PPI can be given. I am writing one pantoprazole. Okay, any kind of PPI should be given to the patient. Okay, you might use omeprazole as well. I'm writing the pantoprazole, so one kind of PPI should be given to the patient. Okay, so one is this cap therapy. And if somehow there is peptic ulcer disease and the extent is much more as you saw in your patient, then you might add one more drug. You might add one more, and that can be the metronidazole over here. Okay, that can be metronidazole, so that can also be used over here. Okay, fine. Now let's say, so this was the first one where we have discussed that if it is H. pylori induced. Okay, and what will be the time duration over here? So 1 to 2 weeks for it can be used, up to it can be used for 1 to 2 weeks. Okay, and you will be calling the patient for the follow-up and you will be checking further. Fine. Second cause over here which I would like to mention. Second cause, so first cause we talked about the H. pylori induced peptic ulcer disease, and the second one, after H. pylori, much more famous, that is the NSAIDS induced, because as I said, it is very commonly used by the population nowadays in today's lifestyle, painkillers, right? And mainly aspirin I'm talking about. So if it is NSAID induced peptic ulcer disease, NSAID induced peptic ulcer disease, so then what we need to give? Simply we will be telling them that please stop your medication right now, stop the NSAID, stop. If the person is taking, let's say, ibuprofen, or if the person is taking, let's say, aspirin, so please stop the uses of this drug, and then we will be introducing the PPIs, that is the proton pump inhibitors. Okay, that is the proton pump inhibitors. Okay, and you know the proton pump inhibitors from the pharmacology, that omeprazole, pantoprazole, right, rabeprazole, lansoprazole, these are prazoles. These are the, yes, so the drugs which are ending with the prazole, yes, so these are the PPIs, right, proton pump inhibitors. Then if the ulcers are bleeding over there, then you need to give the IV fluids to the patient. You need to, sometimes if the bleeding is much more, then you may give the blood products as well in those patients, right? So that can be given, and because the bacteria might develop, so intravenously proton pump inhibitors can be given in those patients, right? And in the perforating patient, surgery has to be done in those patients, right? For the perforation, so I will just write rather than talking it verbally. So if the patient comes with the much more severe condition, if there is a perforation, then obviously surgery is the better choice. So surgery has to be done for that patient, isn't it? So that's how it goes. Okay, and at last, if you talk about the complications, however we talked about them previously as well, but at last, if you talk about the complications of such patients who are having the peptic ulcer disease, then complications are very important. As I told you that bleeding might happen in our patient. Okay, so bleeding might happen. Then I told you if they will be bleeding, so I told you the perforation component, the perforation is very important. Surgery might be needed in these cases. Then sometimes I told you one more thing, that is about the malignancy, and mainly the gastric ulcers might develop into the malignant ulcers. So malignancy can also be the risk after the development of the peptic ulcer disease, right? So that can also be the thing which can be considered under the complications, right? So now what I will be doing, I will be actually inserting one image, actually two images, which will be clearing our concept much more further. So you can see the peptic ulcers over here, that how they are looking. Okay, so over here what I can see clearly, that this was the healthy stomach, and you can see the beautiful lining, epithelial lining over here, and over here the lining are disturbed, and here you can appreciate the duodenal ulcer that is present in the proximal part of the duodenum, as I said, and then gastric ulcers are developing over here, right? So here you can appreciate the gastric ulcers. Okay, so here the vomiting might develop, or vomiting can be there in the gastric ulcers patients, and over here the okay, and over here what might happen, yeah, melena component might happen, so black terry stools might develop over here, right? So that is the ulcerated stomach, and on the left side you saw the healthy stomach. Okay, now you know the concept very well. Fine, the next image over here, which I thought that I should insert it. So over here you can see the H. pylori with the green color bacteria, okay, the nasty bacteria which is responsible for all this. So H. pylori bacteria over here, and there it is causing the destruction in the epithelial lining. So I told you in the initial part that ulcers are basically, they are the erosions or some kind of defects in the epithelial lining. If it is presenting in the stomach, then there can be the gastric ulcer. If it is presenting in the duodenum, then there can be the duodenal ulcers, right? So over here H. pylori are basically causing the problem in the both gastric as well as duodenal, but gastric definitely are on the higher chances, right? Gastric ulcers. So here you can see the protease which are produced from them by these nasty bacteria. They can cause the damage in the epithelial part. Okay, the erosions might happen, and you can see even the muscularis mucosae might be involved over here. Okay, if you talk about the layers. Okay, and the inflammatory part will be coming over there. So there is the gastric ulcer. Okay, I told you one more thing, that further there might be the chances that malignancy might develop further. Okay, so there might be the chances that malignancy part may come further in this patient. Okay, so that you need to remember. So that's it guys for today's discussion. So we have talked about the peptic ulcer disease. I hope you enjoyed the discussion. Please go through it once again, and if you are having any kind of doubt, please drop them in comment section below. I would be happy to answer them. So that's it guys. Thank you for listening to me, and I will be seeing you in my next one. Thank you so much.